Okay, so welcome everyone. We will get started in about 1 minute to give more people time to come on. And then we'll start with an brief overview, an introduction of our speaker. And then we would turn it over to the speaker. And after that, hopefully we'll have a little time for a question and answer. So we would ask everyone who's come on if you can mute your mic. And we'll get started. I'm sorry. I realized that I actually just did all that introduction and my mic was muted. I am so sorry. Let me just be short. We are welcome to Georgia Southern, Lisa M. Carlson, the current president of the American Public Health Association. Please look at the flyer and you'll see that Ms. Carlson is also the executive administrator for research and programs at the Emory School of Medicine, as well as an adjunct with the Rollins Schools of Public Health. So welcome, Ms. Carlson, to Georgia Southern. And at that moment, then I'll turn it over to you. Thank you very much.
Thank you. I really appreciate the invitation to be with you. And I'm sorry that we are not together in Statesboro. I live in Atlanta and I have yet to be to Statesboro, although I see that it looks like a very pretty place. So hopefully at some point I will get a chance to be with you there. But I want to thank you very much for the invitation to talk with you today. Give you a little bit of a sense of where we're headed. I want to talk a little bit about my own journey in APHA, about APHA and about JPHA, the Georgia Public Health Association, which I hope will be of particular interest to you. I want to talk some about the tough questions in public health, how we should cross sectors for public health, get into what I'm calling some of the messy stuff of public health, and then we'll finish with some ideas about leadership. I want to bring you greetings from Emory. I like to say that Emory is the place where the score is Emory 4, Ebola 0. This is Dr. Kent Brantley, who was the first patient on US soil with Ebola as he was being discharged from Emory Hospital. I suppose I will now have to update this slide with greetings from Emory about the successes we are hoping to be having in COVID. But in any case, well, greetings to you from Emory. So let's talk a little bit about the path we take, your story, how you got here, how you felt prepared to get here. I think one of the things that I tell my students is that we are rarely in fourth grade growing up to say, I want to grow up to be in public health. It's just not the sort of thing you hear little kids say, I want to grow up to be in public health. And so most of us have a story. You know, I teach my students, if you're at a networking event and you don't know how to start a conversation with someone, one of the most interesting things you can do is say to them, how did you find your way into public health? Because we all have a story about that. And our leadership is really the same kind of idea. So I'm going to tell you a story about my start in APHA. It was a long time ago. I was freshly out of graduate school, and I was giving a presentation in what was a very large ballroom. And it's probably one of the largest ballrooms I had spoken in at that point. And it was on Halloween Day, and I was giving what was a little bit of a controversial talk from the funder that I had worked for, who was called at the time HCFA, the Healthcare Financing Administration. It's the precursor to the Centers for Medicare and Medicaid Services. And as I gave the talk, the lights in the ballroom went up and the lights in the ballroom came down. And it happened again and again. And I made a little bit of a joke about it being Halloween and there being ghosts in the room. And as I continued, the lights went up and the lights went down. And I finally said, somebody at HCFA doesn't want me to give this talk. And the lights went out at exactly that moment. I couldn't have planned it any better or worse, depending on how you look at it. It was an auspicious beginning to my time at APHA. My first lesson, though, really at that point in APHA was that it's a bit of a behemoth. I don't know how many of you have been to an APHA meeting or active in APHA, but it is a large association. And so just a few comments about the difference between APHA and JPHA, the Georgia Public Health Association. Both of them really have important roles to play. So in APHA, really section-based, discipline-based, science-based, and the affiliate really is the most important grassroots advocacy and local connections organizations that we have across the country. So I bring you also greetings from APHA. We champion the health of all people in all communities and strengthen the public health profession. We're the only organization with a nearly 150-year perspective on public health. I suspect that, that most of you, if not all of you, are familiar with this from Dr. Telfair's presidency in APHA. My personal love for APHA started in my affiliate here in Georgia. I got involved back in 1994 because my mentor nudged me in a business meeting and said, "Are you ready to get involved?" And I did, and have never looked back. I think the affiliates, if you are not active in JPHA, I would encourage you to check us out. We are, as affiliates, key to the grassroots advocacy, which is the folks who are implementing the policies at the APHA level. I think it's fertile ground for local networking, whether that's for early career professionals or students. Really accessible places to start, I think, are in the affiliates. You know, I talked about APHA being a behemoth, and sometimes that more accessible size of an affiliate meeting is a good place to start. And then, as I said, I got involved because my mentor told me to. And so each of us as mentors have a strong influence, and hopefully we can use that to talk to the next generation of public health professionals about how important it is to give back to the profession. And we can do that in ways like service through APHA and JPHA. I'm probably not going to be telling you things you don't know about public health challenges in Georgia. We have the third worst rate of uninsured. We did not expand Medicaid under the ACA. Our obesity rate has increased every year since 2011. We rank in the bottom third of states for premature deaths, infant mortality, and diabetes. So we have work to do here in Georgia, and I imagine many of you are actively involved. If you think about sort of our perspective as an affiliate over the years, when I first got involved in JPHA, we were trying to figure out how to be accessible to the local Georgia workforce and still engage members who are working at the national level. CDC is here in Georgia, and we don't have a huge membership in JPHA of CDC staff. So trying to figure out how to be accessible both locally, regionally, and nationally. I know that there is sometimes a perspective that at APHA is too liberal for Georgia public health professionals, but I do think that there is a shared vision that we have about the power of public health, particularly in times of crisis like now. I think there's a lot of work that we can agree on. And so I think there's a lot of things that we can do together. We've had a lot of success as an affiliate, and this is just a few examples of that. We started an academic section, which might be of interest to you at Georgia Southern. It's a section that is focused entirely on folks who work in academic environments, and so give us a place to talk and work together. We have started 9 student chapters in public health programs across the state. We have a career development section, which has a seat on the executive board. And you can see there some of the bills that we've been involved in, either supporting or opposing and having some success with in our lobbying efforts with GPHA. I think the thing we are possibly most proud of, and you are probably familiar with, is that Georgia had a division of public health within the Department of Human Resources, and the state health officer did not have a direct reporting line to the governor. GPHA was very involved in advocacy that led to the creation of the standalone Department of Public Health that Dr. Kathleen Toomey is now leading in this very important time. There's direct reporting to the governor, and I think it was a prescient move that we did that, and statewide advocacy really works. It's a good example of that. I will say this, the standalone Department of Public Health is still separate from behavioral health, and we'll come back to that actually a little bit later. So one of the things I have been saying in all the years I have been involved in APHA and GPHA is that regardless of where we practice, we all live locally. And so I think folks who are involved and active in APHA, I encourage them to get involved in their local state affiliates because of that local piece that's so important. And it really strengthens our collective voice, which I think is our greatest strength. So these are the times that we want to come together and advocate collectively for public health. And that's really what sets us apart at APHA is our advocacy. So we take the scientific expertise of those sections at the national level, the local network of affiliates, and that really sets us, I think, apart. And one of the things that's important is being able to tell the public health story to non-public health audiences. And I think that's a key role for places like us in Georgia, translating our best science into understandable recommendations. So you take the average layperson or the average legislator maybe, and you know that they don't necessarily understand public health as a discipline, but they understand that they want clean and safe places for their kids to play. They want clean water and clean food. They want us to be ready to deal with pandemics. And so it's really filling in those gaps in knowledge and understanding is a role that we can play through APHA and our affiliates. And so that really brings us together to sort of thinking about our advocacy role at the national level, which is clearly really important all the time, and certainly more important than it is right now. So there are some programs at APHA you might be aware of. Speak for Health, if you're a hashtag person, hashtag Speak for Health. Clearly advocating for funding for public health is going to become even more important in these times. And so there are action alerts and other things that you can get involved in. I'm looking ahead to our 150th anniversary meeting in Boston, Massachusetts, and obviously hoping that we will have our APHA annual meeting in October in San Francisco, and that we can be together in some way at that time. I want to sort of translate now to talking a little bit about what I'm calling the tough questions, which is about creating a healthier context. So the Robert Wood Johnson Foundation said a decade ago, it's time for America to lead again on health, and that we needed to stop thinking of health as something we get at the doctor's office, but instead something that starts in our families, our schools, our workplaces, our playgrounds, in the parks, in the air we breathe, in the water we drink, and understanding that the things that have enormous impact on our health are not the things that we find in doctors' offices. So what determines health? Healthcare is just a minor piece of that, 10 or 20% of it. More than 50% of it is made up of the social determinants of health. And you can see there some of those other sectors that we'd be talking about. That'd be housing, transportation, education, food. The healthcare system is certainly part of that, but all of these other places are folks that we want to figure out how to partner with. Because we know that there are a number of challenges that are really writ large. So one of them is the geographic disparities in life expectancy. So we know that at the county level, there are large and increasing disparities in life expectancy, and that socioeconomic and race and ethnicity factors explain more than 60% of that variation. And the variation is large. I have seen it quoted as more than 15 years or as many as 20 years difference in life expectancy between the richest Americans and the poorest Americans. And it's not just life expectancy, but the number of healthy years during that lifetime. And they do vary quite a bit based on these social determinants. And we can see where that comes from childhood. So what you're looking at here is the Robert Wood Johnson Foundation's Opportunity Atlas. And what it's showing you is it's tracking children's outcomes in adulthood based on household income in their childhood. And so you can see, this is by every census tract. So this is very, very small places and very, very big data. And what they found is that if there are positive influencers on outcomes in adulthood, they matter even if they're just a few miles apart. So what does that mean? It means that there are these key stepping stones like access to good schools, affordable housing, safe neighborhoods, and quality healthcare. And when those things are distributed in ways that help outcomes in adulthood, they help health in adulthood because there's a direct line there. But when they're unequally distributed, then certainly health outcomes are certain to be inequitable as well. And so we know that today a person's zip code may be a stronger determinant of health than his or her genetic code. And I find that really startling. I don't think it should be true that circumstances like zip code should predict a child's health or an adult's health for that matter. But in fact, your zip code determines the quality and access to things like schools, jobs, housing, grocery stores, community safety, and green space. And this idea of green space is one that's particularly important to me. I have actually been doing a lot of conversation this week about trees and the importance of trees, and as we are isolated in our homes, the importance of getting outside into nature and among the trees, which I see as part of the public health team. And we really know that the tree canopy varies by neighborhood, by income. So that in poorer neighborhoods that have fewer trees, they can be as much as 10 degrees hotter than wealthier communities in the summer heat. And that has a direct impact on health. One of the other things that we know about walkability is that it impacts social class, which impacts health. So there are large regional differences in upward social mobility, and we have looked at a study that shows that the walkability of a city is key to this. So it makes sense if you think about it. If somebody has a walkable city, they're less reliant on cars for employment, and maybe they feel a greater sense of belonging to the community. Those things are both associated with actual changes in social class, which is associated with changes in health. We know that there's an effect of poverty on our genes. This is new research that's epigenetic research. While we've long known that socioeconomic status predicts health outcomes, they've recently shown that poverty really leaves a mark on the genes in the genome. And that matters because it can have a lasting impact on any number of systems. Now, more research needs to be done to understand the impact of that on health, but I find it startling that you can see this at a genetic level. And so it's really a problem writ large. So I imagine most of you know who Dr. Bill Foege is. He's a former CDC director and a public health hero. He played a key role in the global eradication of smallpox in the 1970s, increased rates of immunization in developing countries in the 80s, and he's really still changing the world. He's at the Gates Foundation. I live in Decatur in Atlanta, and we have every fall a book festival. And Dr. Foege was here to talk about his book a couple of years ago. And somebody asked him a question at the end. They stood up and they said, you know, Dr. Foege, if you had it to do all over again, all the things that you've done in public health in the decades, what would you focus on if you could start all over again? And he stopped for a minute and considered, and he said simply, poverty. And he said that's because of its dose-response relationship with health. And that if we could change anything at all to try to change health, we would change the inequalities that come from poverty. And that's a big job. If you think about what we're going to need to pull together to make impact on the social structures that are in place that lead to inequality and lead to poverty and lead to poor health, we're not going to be able to do that by ourselves. So this takes us to thinking a little bit about Public Health 3.0 and crossing sectors for public health. If we think that avoiding smoking, avoiding obesity, increasing physical activity, and improving nutrition are primary prevention, then what are the activities before that? If we can think of those as primary prevention, those are really the social determinants of health. So health begins where we live, learn, work, and play, as we started at the beginning of this conversation, and begins in our families, neighborhoods, schools, and jobs. And so we want to intervene at the community level and make use of good data, because communities have to determine how best to use their data in their own backyards. It might be different in Decatur than it is in Statesboro. Our data may be different, and our use of those data may be different. And Public Health 3.0 is really about building capacity to address the social determinants of health, as well as other traditional public health challenges, by using data in our own backyards. So it's a call to action for the 21st century to think about what we do together as a society to ensure the conditions in which everybody can be healthy, right? How do we work together to do that? And at its core, it's really about local public health having the capacity to address the system level issues like social determinants of health. So again, there on the right side, you can see education, employment, housing, food, transportation, healthcare. These are these sectors that we need to convene in cross-sector conversations to increase access to positive social determinants. And I really think that public health and local public health are the people who are going to be best at convening those groups to come together. Because ultimately, we all have the same goal, which is that making the healthy choice is the easy choice. And as important as it is to support an individual, it's really about creating a context that allows for a person to make healthy choices that I think is going to have the greatest impact. So cross-sector synergy to create those conditions to allow people to be healthy will involve all of those sectors that I mentioned earlier, and bringing them to the table, bringing them together to think about how we work together to do this. So how do we do it? Well, Public Health 3.0 looks like this. We want to form unexpected cross-sector partnerships with community stakeholders, which could be from any of those groups or other groups that we've talked about. That somebody really has to embrace the role of chief health strategist throughout the community. I understand that some folks in local public health think that maybe that's a role that's a little challenging for local public health, but it doesn't necessarily have to be us. It could be from one of our partners. Although as we enter into this pandemic and this crisis, I think putting public health front and center could be very, very powerful. So something for us to think about embracing. We want to build infrastructure from public health department accreditation to maybe umbrella structures that share funding and governance. We want to enhance and modify public health funding, no more important than right now, and make available timely, reliable, and actionable data, which is also, again, no more important than right now. There are some resources for thinking about how to do this. I want to point to just two of them. They come from the De Beaumont Foundation, and one of them is the Practical Playbook 2, which is really a roadmap for health improving partnerships, and you can find that online. The other thing you can find online is Phrases, which is public health reaching across sectors, and it supports an all-hands-on-deck approach to looking at those various sectors, and you can see them there again: housing, health systems, education, and business. I'll give you an example. This is Air Louisville is a great example of the Public Health 3.0 experience. So what they did was they were having a problem with asthma and admissions to ERs with asthma attacks in Louisville. And so they said they wanted to try to figure out how to approach that as a group. So they got government, nonprofit, and the tech sectors all together, and they created inhalers with little electronic sensors in them. And so they could distribute those inhalers, and then they could crowdsource real-world data about people's use of those inhalers and create a heat map of areas that clearly had concentrated pollution that were setting off those asthma attacks. And they changed care plans. Certainly, there was a healthcare argument to what they did here, but they also made policy changes. They planted trees. They changed zoning. They rerouted trucks. I mean, they planted trees and rerouted trucks. This is not necessarily the sort of thing we think about as basic public health, but clearly had a huge impact on their success in Louisville, and is a really good example of this kind of cross-sector partnership that I'm talking about. So I think this is the future of public health. I think working with people outside of traditional public health, everybody doing the part that they do best, it's all linked, because really we're going to have to come together and think about all the ways in which our different pieces of work overlap, so that we can all make success together if we're going to think about these problems writ large, like poverty. Now, you might wonder, if we're going to do all of that, what does the public health workforce look like? Who can pull that off? So there are about 200,000 people in local and state public health. We know we've lost about 55,000 public health jobs since the Great Recession. The public health workforce is older than the US median age, and there are more people than the general public eligible to retire in the next few years. And then about a quarter of local public health is thinking of leaving public health for reasons other than retirement. Those generally are low wages or bureaucracy. So who's going to replace those folks? Well, you might think it's our students, but really the MPH isn't the entryway to the public health workforce. About half of local public health doesn't have an MPH. And only 14% of government public health has formal public health training at all. Our schools of public health in this country graduate about 30,000 students a year. Most aren't going into governmental roles. They're going into academia, hospitals, not-for-profits, for-profits, and technology. And I would argue actually that in a not necessarily intuitive way, that's good for us. Because I think this creates a cross-sector public health workforce. And this is, cross-sector is really people who don't live and breathe public health or don't think that they do. But if we've got MPHs in all these other sectors, they've got a shared concern and a shared lens with us that they can bring to the technology sector that they're in, or the education sector that they're in, the academic or healthcare sector, and bring that to partner with local public health because we're speaking the same language. So I think one of the things we want to concentrate ourselves on as public health professionals is how can we be connectors and mine non-traditional partners to expand the public health team. I have long thought that as in a university environment like the one I work in, we should be reaching out to departments of religion, political science, psychology, and others, and asking students, are you interested in social justice? Are you interested in applying science for practical solutions to problems? Have you thought about a career in public health? Have you thought about partnering with public health? I am a person who was trained in public health, active in public health. I work in a school of medicine. I'm a practitioner and I work in an academic environment. I am a non-researcher whose job it is to steer and improve research. So I think those kind of non-traditional entryways and connections are really important for each of us to think about. What is the way in which you connect different people in your community so that we can, as collectively as public health, be people who connect other people to us and help us think about how we accomplish this mission together. Speaking of working cross-sector, I want to talk for a second about what I think of as the tough questions and messy stuff. I got asked last year what my vision would be for public health as APHA's president, and I highlighted these 4 things here that I wanted to make sure to talk about this year: universal access to quality healthcare, a strong, well-funded, and responsive public health infrastructure, protection of our natural resources. I talked some about those trees, and that mental health would be recognized as essential to public health. I want to spend just a minute on that. Public health isn't easy. I think we are obligated in public health to talk about the hard things. We got into public health knowing there may be messy work to be done. My father-in-law, Dr. Alan Hinman, who's also a public health hero and a worldwide expert on vaccination and immunization, he teaches a class on healthcare. On human rights, healthcare and human rights. And one of his students asked him one day about trigger warnings and whether his class, thinking about human rights abuses, ought to come with a trigger warning. And he thought about it for a minute and he considered and he said, a career in public health ought to come with a trigger warning. Because we do in public health deal with the hardest things, the most difficult things. And one of those I think is mental health, and that there really is no physical health without mental health. The median years of potential life lost due to mental disorders is 10 years in a recent study. That's 10 years of life lost. About 14% of deaths worldwide, which comes to 8 million people a year, are attributable to mental disorders. And mental and physical health are connected. It was about a half a century ago when it was said, without mental health, there can be no true physical health. And today we have really strong evidence of the bidirectional link between mental health and physical health outcomes. Health really isn't a single factor, and these things are connected in ways that we have to pay attention to. Yet mental health and mental health challenges remain highly stigmatized as health concerns. If you have a physical health diagnosis, you might garner sympathy for that diagnosis. But a mental health diagnosis could elicit judgment, fear, or avoidance. There's a study that said that 8 in 10 workers with a mental health condition didn't get treatment because of the shame and stigma associated with it. The problem with that is that most of us know somebody who struggled. About 20% of US adults experience mental illness in a year. That's 1 in 5. So most of us know somebody who struggled. And there's a small number of people who are living with severe problems like bipolar disorder or schizophrenia, but a large number of people, 42 million living with anxiety disorders, 16 million living with major depression, 15% of US adults struggling with substance abuse disorders, which is on par with the number of people who have diabetes, and about 1.5 times the annual prevalence of all cancers combined. And when you think about the impact that we have on families and communities and employers, and all the folks that those folks touch in their lives as they struggle, that impact is really broad, and most of us are touched in some way by this. I am passionate about this from personal experience and family experience with mental health challenges and the inequity of our system and the stigma here. I am not a mental health professional, but I'm a person who's passionate about it because I think we really in public health need to be thinking about how we integrate mental health into what we do. And we should, as public health professionals, be passionate about mental health. These hard things are all really interconnected. Poverty, unhealthy environments, violence and suicide, substance abuse, mental health, they're all connected. And health, being a product of the context in which we live, is really both mental and physical. And if we think about the kinds of things that cause stress at the community level, so public health, we like to think at the community level. There are community level stressors and community level interventions. So if we fix the structures that generate income inequality, it's going to make a difference in physical and mental health. If we, there's a study that showed that if we increase the minimum wage by $1, that results in a 3 to 6% decline in the suicide rate. So there's a direct connection. If we think about what happens in a community, if there's a layoff at a major employer in the town, if there's a closing of a car plant, which there was a study that showed that was a direct link to an increase in opioid deaths in that community. If a food market that's the only one in a neighborhood closes, if there's an impending tornado or a hurricane, or if there's a pandemic and everybody is isolating at home alone, these are the kinds of community stressors that impact both mental health and physical health. And so we really can't fix one without the other, and they're really interlinked because they're impacted positively and negatively by the same factors. And these same factors are the ones at play in creating contexts in which people can be healthy. So those same things you see there on the right: education, employment, safe and affordable housing, healthcare, transportation, food, access to nature, which I've talked about, exercise. These are all linked to each other. And the same factors and social determinants are the concerns of mental health and physical health alike. This is public health. And public health is the right group to promote discussions about these links because we can make the biggest difference in this in cross-sector partnerships. This is our lane. So I want to really encourage you to include mental health in all discussions of public health, particularly in discussions about COVID-19 and how we cope, and bring those things together. So let me just think a little bit here towards the end about how we can be leaders, whether we are leading in COVID, if we are leading in public health, if we are leading in mental health. Everyone is a leader, and I want to just talk for a second about leadership. My vision for APHA, talk about the hard questions and the messy stuff, to bring up this issue of mental health for us to consider. I want to represent the whole association and its priorities, and have been trying to do that, to really shape the debate locally, nationally, and globally by defining public health broadly. I think all of those other sectors that I've been talking about have a role to play in public health, and right now, everybody's second job is public health, as Dr. Benjamin has been saying from APHA, and we are all doing public health by staying home. I have an interest in deepening connections among affiliates and sections, so hopefully you are involved in JPHA and APHA, and if not, have been inspired to check us out. I would like to increase membership in both, because I think there are some very basic life lessons that we can apply to our work in public health. Expecting the unexpected sounds almost, it's almost get a good chuckle out of that right now, because we have all the unexpected right now. Trust that it's never too late to change, owning your mistakes, seeking mentors, exploring options, being a good communicator, finding joy at work, and pushing boundaries. And I would add to that crossing sectors for public health. And so I'll leave you with this. Please share this with others. This comes again from my father-in-law, Dr. Alan Hinman, and he says, if you want to have a good career, you really have to meet 4 conditions. You have to find something that you like to do, that you're good at, that helps others, and puts food on the table. And he says, if you want to have a great career, you add a 5th condition, which is to work with people you like in the process of doing all of those things. So I would share that advice with you. And with that, I would say thank you to Georgia Southern, to Dr. Telfair for the invitation, to all of these other folks, APHA leaders, to Emory for what would have been time away from the office today is just time online. And I have been thanking all along here my wife, who has been my greatest support in the time that I did be away from home, and in this time in which I am online too. So thank you very much. I would encourage you, if you are on Twitter, to engage with me on Twitter at Carlson Lisa M, and continue this conversation over the course of the year. Dr. Telfair, back to you.
Thank you so much. And thank you again, Ms. Carlson, Madam President, for participating in our grand rounds. So for the persons on, I did not see questions in the chat room. So let's open it up, your mics. And we have, for the graciousness of Ms. Carlson, we do have a good 20 minutes or so for questions. So anybody have any first questions, please just unmute yourself and move forward. Okay, well, I'll start. I appreciate tremendously the emphasis that you have on the two areas that are critical to us, which is, one is poverty and the inequities that go with poverty, and the other, of course, is mental health. Could you speak a little bit about, for the last one in particular, a little bit about concrete things that we as public health persons can do with mental health, since that is a growing need. It was a growing need prior to our current circumstances, but it's significant now.
Yeah, thank you for the question. I think the biggest thing that we can do as public health professionals and advocates, and frankly in our families, is to talk about mental health. And so I think as we are people who are in positions to be thinking about public health policies and public health interventions and how we actually do our work every day, that the biggest thing we can do is bring mental health to the table. Very often those folks are not included in what we're doing, and so just adding them into the conversation is really important. That's especially important, and as we talk about how we're going to address COVID-19, I think the vast majority of us found ourselves going home on a Friday and not going back out on Monday morning. There wasn't a lot of warning that this was coming in this way, and so not having really had time to prepare for this, I think we do have time to prepare carefully now for the impending mental health lingering challenges that are going to come out of this. I have been talking some through APHA about how we can be encouraging self-care. They know that in the healthcare professionals in Wuhan, China, showed significant mental health challenges after their initial interaction with this pandemic. And we know that our own folks are going to have those same challenges. People are having those challenges now just from being isolated at home. And so, there are basic self-care things we can encourage our public health friends to do, which is, to take breaks from the news, to make sure that they're doing the basics like eating well, sleeping well, moving around during the day as we are stuck at home, getting out into nature and really safely out into nature to be centered by that. Some sort of basic things that we can do, not the least of which is staying connected to our social networks. I'm not a fan of the social distancing language. I prefer physical distancing and emotional connection. I think video chats and video happy hours, waving to your neighbors, these are all really important things right now. So having that in the conversation, being part of the conversation, making sure that we bring that up every time we get the chance, that's the shorter answer.
Yeah, we appreciate that. We've been sharing, our community partners have been sharing mindful self-compassion sessions with us, and we've been taking advantage of that. So I see a question. Ms. Hill, do you want to, you have a question or comment? If you can unmute yourself and ask, Ms. Hill. Okay. No. All right.
Dr. Telfair, this is Bill Mays. Can I jump in with a quick question?
Of course, Dr. Mays.
Thank you so much for your presentation. It's excellent. I had a quick question on specifically with regard to mental health, behavioral health workforce shortages in Georgia. Mm-hmm. Dr. Jiann-Ping and Dr. Tarasenko and I, about 6 years ago, had been looking at workforce shortage specifically in some of the most vulnerable rural parts of the state, and how much undersupply of behavioral health professionals we have, and then now looking at what we've got ahead, do you see that as an opportunity? I mean, clearly that's a loaded question, but what do you see as some of the strategic pathways towards promoting improved access to behavioral and mental health services, specifically for our rural populations, but I assume that's also an urban problem?
Yeah, good. It's a great question. Thank you for the question. I think that that we know that there are challenges with having access to mental health professionals. There's no question about that, and I do think this is an opportunity to try to bring light to that, to try to similar to the bringing light to the fact that we have lost so many jobs in public health that we need to replace and grow. And so I think similarly in mental health, one of the things I think that there is good light at the end of the tunnel about here, though, is that the role that telehealth has to play. A lot of mental health professionals are offering their services online, and a lot of insurers are coming to the table to pay for that in this environment. And so hopefully that's something that we keep in the future as we go forward, and we don't take a step backwards with that, because I think that would particularly help in the rural populations you're talking about, but I think can help a lot of people to access people a little more easily.
Thank you. Other questions?
Hi, Dr. Carlson. My name's Ashley. I'm an MPH student on the Savannah campus. I also work with food access in the city of Savannah and food justice issues related to food deserts in the communities. And a lot of what we've been seeing for the last few weeks is just kind of an emphasis of things that we already knew were problems, but have just been really highlighted by the fact that, you know, everything is really exaggerated right now.
Mm-hmm.
So I'm just wondering if maybe APHA or JPHA has any thoughts about, you know, how to kind of use some of this information we're gathering right now and kind of direct it in a helpful and a proactive light as we move forward and kind of address some of these problems.
Sure. Well, let me thank you first for being here. I think our students are our future, and so it's really nice to have you with us. You know, you're right that everything is exaggerated right now, and one of the sort of things that we can harness to try to bring together about that, though, is to, while people are paying attention to public health, to try to help them understand the reasons why we are struggling right now, which is that public health gets a lot of money when there's a crisis, and then things go along pretty well and it gets defunded, and then there's a crisis and we struggle, right? So we have to fix that process and fix that funding gap and the sort of mistiming of how that works. And the biggest way that APHA is working on that right now is through advocacy. And so whether it's food shortages, mental health shortages, funding shortages, all those things that are interrelated, to try to be pushing our lawmakers to say, if you're doing stimulus bills, you have to be including money for CDC and local public health. We have to be trying to replace those jobs that we lost. You know, our voice collectively at APHA, we are about 25,000 members in the National Association and about another 25,000 in the affiliates. So that's 50,000 strong. There's a lot more people in public health who have not yet joined our ranks formally. If we can get those people to join us, especially in this time right now when it's so important to show that public health has a solidarity and a message together, I think there's power in that, in going to our elected officials and saying, we really have to fix this.
Thank you. Other questions?
I have one quick question.
Please.
Hi, so my name is Sonam. I'm a second year MPS student here at Georgia Southern. And so you mentioned about getting involved with APHA and JPHA. So I was wondering, what are some ways that we can get involved in these organizations?
Oh, good question. So as students, the first place I would send you is to APHA Student Assembly. I mentioned all those sections that APHA is broken up into. The Student Assembly sort of crosses them all while folks are students, and they are 8,000 members strong. So they are by far the largest group of folks at APHA. They are incredibly well organized. If you go to apha.org, to the website, you can look up the Student Assembly and find their chair there and some of their committee chairs, and email somebody that shares a committee that you think you'd be interested in and get involved. I think reaching out to the section chairs and committee chairs and the Student Assembly chairs to see what's the best way to get involved in something that interests you is what I would take as the next step. There are also, as I said, these student chapters of GPHA around the state. And so getting in touch with them, GAPHA.org is the GPHA website. Any of those student groups, I think, would be the first place to start. And then hopefully you'd find your transition into a section home after that. But the students are all very well organized at both levels. And I think you'd find a lot of good there.
Okay, thank you.
Yeah.
Thank you.
Thank you, Ms. Carlson, for mentioning that. Just a reminder, we do have a PHSA section here at our college, which is one of the affiliates. So if you could reach out to them, we could, that will be great. And it's on our website. So
Excellent.
Yeah. Other people.
Hey, it's Denise Hill
There you
here.
go. There you go. Okay.
I had trouble finding the unmute button on the thing, but yeah, I've been licensed as a social worker for about 15 years, and have practiced with first with family and children with defects as a foster care case manager, and then once I got my clinical license with severe and persistent mental illness and locked units, and then seen how with the deinstitutionalization, people went from being in Georgia regional hospitals for years, and then into a more confined environment, into nursing homes, which are not set for behavioral health, but set for, skilled nursing facilities, and then ended up in private practice. And so over those 15 years, I've worked with a wide variety of mental health, and then I decided that I wanted to get a public health doctorate to take things from micro into macro population health wise. And in Georgia, we really have a history of not doing very well by our mental health, right?
Right.
We got sued, the state got sued by the U.S. Department of Justice because our public mental health issues, public mental health services were so bad. And so I'm having trouble kind of getting connected with other people in the public health field. So I guess the same thing as what you're saying is get involved with APHA and things like that. And that way I can kind of feel like I have other people in the public health field in the same, like within your tribe, right? Because you're saying public health is, mental health is going to be a big thing, or it needs to be a big thing.
Yeah, and I would thank you for the work that you're doing. That's good and important and hard work. There at APHA, one of the sections is the mental health section. And
yes, it's on the APHA site, but not on the Georgia.
Yeah, Georgia doesn't specifically have a mental health section. So in Georgia, you might find it in maybe in the public health and health promotion section might be some of those folks. So they'd be a little more spread out among the other sections in GPHA. But at the APHA level, definitely a mental health section. Those folks have been incredibly supportive of me as I've been out talking about mental health this year. Really active section, lots of ways to get involved.
Okay, great. Thank you so much.
You bet.
Okay, others.
Hi, this is Jessica Schwinn. I wanted to thank you so much for coming to speak with us. I was super excited to hear of your interest in preserving our natural resources as one of your goals. I'm actually on the executive team for the APHA Veterinary Public Health SPIG.
Oh, great.
We're one of the last SPIGs in APHA actually, so we're hoping to get section status soon. And we advocate for a One Health approach with health professionals in the group that span across human, animal, and environmental health sectors. I was just wondering, what are some of your goals within this area of focus? And feel free to let the VPH SPIG know how we can help you in supporting you on this journey.
Thank you. I appreciate that. I've been to some of your sessions before. I think you guys are a great group. I hope you do get to section status.
Thank you. Thank you.
In my own personal One Health approach during our COVID isolation is that my cat is usually right here in my video. But I did walk him out today. You know, this issue about natural resources is really important to me. I believe that our outside spaces are sacred spaces. I go out and walk every morning and see the sunrise every day. I find it centering and grounding. It's good for my physical health and my mental health. And I think that right now, especially encouraging people to be safe when they go outside, certainly, but to make sure they go outside and feel the breeze and listen to the birds and see the sunrise and, you know, sit among the trees, I think is a really important way to stay connected to things that are larger than the four walls that we're living in the moment. And APHA is putting together right now a press release on my behalf about talking about the importance of sending people out into the trees in general. I think, you know, as I talked about a little bit, trees are part of the public health team, right? They filter water, they exchange the air, they provide habitat, they do all these amazing things. But I think right now they can even be a place that we think about as a refuge. And so I find that to be really important. And hopefully when we put out this press release, it'll get a little bit of attention and we can try to get some conversation going about that.
That's really great to hear. Thank you so much.
You bet. Thank you.
All right. Thank you. Well, okay, anybody else? Okay. Well, we appreciate everybody who's online and especially those that have asked questions. And I would think we wish we could give like a virtual clap to you know, our guests. However, we're going to have to figure out another way to thank her. So with having said that, so Ms. Carlson, you know that we're all appreciative of the work that you do and all appreciative of you taking time out of your busy schedule to come and talk to us here at Georgia Southern. And we also appreciate the fact that you're going to record this and we'll be able to send it out to other people. So anyway, thank you so much for your time, and we wish you blessings and being safe. And I think you will know that pretty everybody who's online and then those who could not join us will give you a great thanks. So
thank you. I see some clapping hands going by up there. So
absolutely, absolutely.
So thank you all very much. I really appreciate the invitation. Happy to be with you.
Okay, then. So we're going to leave it at that, and then what we're going to do a little bit later is we'll post once we get a copy of that, we'll post this presentation on this one, and we'll follow up with you. And then we best what everything you're going to do for the rest of the year. So and hopefully, you know, we'll figure out some way to communicate with you at the end of the year.
That'd be great. Thank you all again.
All right, then. Thank you so much, and thanks everybody. We'll have more grand rounds. That's our work. So please feel free to do that. Please feel free to comment about the quality of the grand rounds here and then the presentations, both the ones that we do for the overall college as well as the ones that our colleague Dr. Fung does as well. So wonderful. Thanks so much. Take care, everyone. Thank you, Ms. Carlson.
You bet.
Take care. All right. Bye-bye.
All right.